Hi, everybody. I'm Nina Boski, and with me is Gary Vitacco Robles. Hi, Gary.
Hi, Nina.
And here we are for our fourth video segment series for Mental Health Awareness Month. And Gary Vitacco Robles is a mental health professional, but he's also one of the most acclaimed biographers of Icon, the lifetimes and films of Marilyn Monroe. Look at how thick this wonderful series of books, both volumes 1 and 2. No wonder you get such raves. And for everybody that is probably most everybody in the Maryland fan base, Gary, you are a go-to person for all things Maryland, and you do her a lot of justice and honor by treating her with respect and love and dignity. And I know I said this in the last series, but thanks again, because I know you get a lot of interview requests, and I certainly did too this last week because Marilyn's birthday is coming up on June 1st. And of course, the main thing is always the conspiracy and who killed her and the murder theme. And, it's always about that. And I love the fact that we can do a series that takes the bright lights off that part of her life and really gives her legacy a beautiful legacy of transformation and taking everything that she went through and talking about it as to help somebody else. And I know Marilyn would really want that, as she is in our background here, if she were with us here physically today. But I have a feeling she's with us in spirit. So with that said, the last couple of weeks we've covered some very deep subjects, right, Gary?
We certainly have.
We have been talking about physical and sexual abuse. Marilyn has had that. We have certainly talked about trauma. We've talked about mental illness as it relates to borderline personality. This week we're talking about bipolar disorder, and then next week we're going to kind of move off and recap everything we've been talking about, but really celebrate the resilience of this wonderful icon and star that makes most of us so attracted to her from the standpoint of her strength and resiliency. But let's get right into it, because a lot of people are confused between what is bipolar and what is borderline personality. What's the difference between the two?
Well, the primary focus of bipolar disorder is that it's a mood disorder. It's a brain disorder, and it usually involves episodes of major depression and episodes of either mania or hypomania. And there's different kinds of bipolar disorder. There's bipolar 1 and there's bipolar 2. But to break it all down, we kind of have to do a 101 on what are these different episodes. So we should start with what is a major depressive episode.
Okay.
So this is you have to have about 5 of these symptoms during at least a 2-week period to qualify for the diagnosis. And this is what we would classically believe as a chemical depression. So there's the depressive feelings that we could all kind of relate to, but is in an extreme: the hopelessness, the changes in sleep, the changes in appetite, this low energy or this fatigue, this slowing down, this inability to experience pleasure in life, which we call anhedonia, feeling worthless or feeling guilty, feeling worried, having very poor concentration, and having extremely negative thoughts or preoccupations with death or suicide. So if someone experiences at least 5 of those symptoms for at least 2 weeks, that's considered a major depressive episode. And that episode can last a very long time as a single episode, or it might end, or it might, a person might experience it, it might lift and go away, and it might come back. And that's a major depression recurrent. And so some folks just experience those symptoms, and we just call that a major depression. What's different about bipolar disorder is that the person may have had that depressive episode, but more importantly, they also have a manic episode. And so let's talk about what a manic episode is. This is symptoms, a person would have to experience about 3 of them for at least a week to meet the criteria for the manic episode. And that is, it's a very expansive, elevated mood state. And for some people, it's that burst of energy, that creativity, but for others, it takes the form more of an irritability, which might be a little bit more difficult to detect. So there's increased talkativeness, they just rapid speech, pressured speech that kind of goes on and on and on from topic to topic. And this maybe increase in self-esteem or a little grandiosity, decreased need for sleep. And this is what's so prevalent in Marilyn's story. She had chronic sleep disturbances, which most likely were clearly a function of this mania or hypomania. And this increase in goal-directed activity, and this is kind of that expansive mood that people can do so much. They can be very creative, they can clean the house, they can organize their garage, they just go on and go on and go on. And it's from their perspective, it's great, they're getting things done, they have this energy, but people around them might see this as an extreme or definitely a problem. And then there's the racing thoughts. And when I think about when Marilyn's journals were published and what her writing looked like, it wasn't a linear diary. It was these jumbles of thoughts on a page that it just looked so chaotic on paper, which I think reflected what was internal in her. She was writing on the margins. She was writing upside down on the side. I think that's just kind of illustrates for us what her rapid thoughts were.
Well, that she's just creative. She's definitely
and this diagnosis is very prevalent in people who are creative, and they can channel that energy into doing wonderful things. So it's kind of a balance, because when the disorder is out of control, it kind of takes over one's life and leads to a lot of dangerous things, but it also brings about this ability to create and produce.
So why is that?
Well, it's just a function of that part of the brain that is impacted in this disorder. It's the part of the brain where the creativity is. This burst of energy awakens parts of the brain and the rest of the body systems in order to carry it out. So it's really something going on, structural changes in the impulse of the brain.
So you had said to us that that the reality of it is that with bipolar, there's bipolar 1 and bipolar 2. What do you mean by that? Is that what you're talking about, bipolar 1 and bipolar 2?
Well, let me just finish the criteria for mania, okay? And then we'll separate them out. There's the racing thoughts, then there's the distractibility or the poor attention, and then there's like this splurge in pleasurable activities, which are often risk-taking, which can lead to some very negative consequences. So the types of behaviors would be excessive spending, excessive sexual behavior, substance use, things that can put someone in quite a bit of danger. So if someone experiences those episodes of mania, that in itself will qualify, at least one episode of mania will qualify for bipolar 1 disorder, but more often than not, people experience at least one major depressive episode and at least one manic episode. Bipolar 2 is a little bit different. Bipolar 2 involves definitely a major depressive episode, but it doesn't require the mania. So there's something that's called hypomania. It's far less elevated than mania. It might not last as long, and it might not be as extreme, and it might not be detected by the person experiencing it, and even the people around them might notice, but it doesn't rise to the level where they might have to be hospitalized. They can still go to work and get things done. They might even enjoy it, but more often than not, hypomania comes across more as an irritability. So in some senses, it's a negative feeling to experience, a syndrome to experience.
So how would you know if you had level 1 or bipolar 2, because that seems a little bit like I could be irritated tomorrow and I could even be depressed, but it's not so much on a degree of extreme, it sounds like.
Yeah, that's why you really need a mental health professional to help with the diagnosis. And the diagnosis might not be easy to determine in a short amount of time. It might require ongoing observation and exploration, and not just an interview of the person experiencing it, but members of their support system, because we have sometimes great awareness into our own symptoms. But oftentimes the people around us can notice things that we might not notice. So unfortunately, with these diagnoses, people tend not to seek out help when they're experiencing mania or hypomania. They tend to reach out when they're experiencing the depression, which is just such a negative subjective experience to go through. So that's when they seek services. So they might be diagnosed having a major depressive episode. The mania just might not have shown itself, or it might not have been accurately communicated. And so oftentimes the diagnosis is missed, except later when the mania comes in force, and it might be in an extreme, or might result in some very negative consequences.
So last week we talked about borderline personality, and I loved how you distinguished the two, because it helped me understand it better, as what I heard was that borderline personality disorder is more relation oriented, meaning that it's something that you could develop, where bipolar is actually something that's going on in the brain.
Well, both disorders impact parts of the brain, but if you consider like a depressive episode, that's related to neurotransmitters in the brain. So like the serotonin level is low. So there's definitely a brain chemistry that's going on. So a lot of the antidepressant medications today are SSRIs, selective serotonin reuptake inhibitors, which just is a fancy way of saying that it's addressing the chemical levels in the brain. We do know that bipolar or borderline personality disorder, which stems from attachment issues and trauma issues in childhood, as the young brain is developing, it will be structurally different and rewired due to those traumatic experiences. So yes, indeed, the impulse areas of the brain and self-regulation parts of the brain are impacted. It's not true major depression and true mania. It's more of a disorder of identity and impulsivity. And you might see much more abrupt types of mood changes than you would see in a bipolar disorder.
So what Marilyn had was borderline personality disorder as well as bipolar, and the combination of those two. And I know last week I tried to drill it in and put it in a nice little box and put a nice little bow on it for anybody that might be watching this thinking to themselves, wow, I know something's going on with me and I just don't know what. And what would you say to somebody that is listening to us, but also clarify for us again, what did Marilyn, if she were alive today, what do you think she would be diagnosed with?
I do believe that she clearly had the bipolar disorder. Her internist, Dr. Hyman Engelberg, did communicate with me in the last years of his life. He told me that he and Dr. Greenson were aware of a bipolar disorder, which back then they called manic depressive disorder. Dr. Greenson was also documenting symptoms that are clearly related to the borderline personality disorder. Borderline personality tends to co-occur with other disorders. And, I could tell you it's common for me in the work that I do to see patients who have both a borderline personality disorder and bipolar disorder. It's difficult to treat, but it's possible to treat, and it tends to be long-term work, and it usually involves some kind of medication interventions. So we know that symptoms disorders can co-occur with each other. On top of all of that, Marilyn likely experienced post-traumatic stress disorder as well, which is very much coming out of her history of complex trauma, and which led to her eventual borderline personality disorder. We cannot give a personality disorder diagnosis to a child, so the person needs to reach the age of 18 to have that diagnosis, but she clearly journaled post-traumatic stress symptoms in her childhood and was triggered all throughout her life. So I think you have like that major trifecta of 3 disorders, which I do see in practice over the last close to 30 years.
Well, let's talk a little bit about the modern day celebrity. And for anybody that may be watching, because I look at celebrities as kind of the microcosm of what's going on in society, right? They're no different than you and I. But let's talk about some of the celebrities of today that may be walking around with either bipolar or borderline personality, or a combination of, right?
Yeah, Mariah Carey has talked openly about it, and she has a great love for Marilyn. I know that during the 1999 Christie's auction, she had the successful hammer bid on Marilyn's childhood white baby grand piano, and I think she named one of her children Monroe. So she's been very open about her illness. I believe Britney Spears has been open about her illness. Shortly before her death, Carrie Fisher talked openly about her addiction issues and bipolar disorder. Russell Brand is understood to have bipolar disorder. Kurt Cobain, Robin Williams, Patty Duke, who's now gone, but she wrote a wonderful autobiography that documented her experience with bipolar disorder. And going back to Marilyn's day, Vivian Leigh had bipolar disorder in its extreme. It's on a spectrum, and Vivian Leigh's was rather extreme. And Winston Churchill is known to have had it, and even Frank Sinatra. And both Marilyn and Sinatra shared the same therapist at one point, who was Dr. Ralph Greenson.
So let me ask you a question about this, because there's a lot of people that I've seen walking around, whether I know them well or just, in touch, whether it has to do with a work situation or just acquaintance situation. And I've watched them and observed them, and you use the term irritation, but when people are flying off the handle very quickly for really no reason at all, or for the reason that they are saying doesn't seem like it fits, how do you distinguish between I'm just angry because I have, pent up anger, and really may have a borderline or bipolar disorder? Because I could almost see somebody going, wow, I get angry really fast, right? How would you distinguish between that and a disorder?
Well, we shouldn't self-diagnose, and that's when we need to see a professional. So, if anyone out there has that concern, they're identifying symptoms in themselves, and they want to know more. They want to know if it meets the criteria for a diagnosis and if they should be treated for it. It's very easy for us to worry when we start to talk about these things, because we begin to see ourselves sometimes in these symptoms. So we really need to reach out and check in with a professional who could spend some time evaluating us. And the evaluation might not be just one evaluation. It might take the course of time, multiple evaluations over time and multiple contacts to really reach that conclusion. But it's a good idea to start journaling moods, because usually these diagnoses, they rise to the level where there's usually a negative impact on in one's life in terms of relationships and their work environment or their school environment, their ability to really function in the world. So, when those type of symptoms begin impacting your functional level and your ability to be successful in your role in life, whether it's as a parent or as an employee, that's when you should be concerned, definitely. But always check out, your concerns with a professional, because the worst that would happen is that you'd discover what's going on, and you'd be able to have a course of treatment for it. But you might also receive some validation that it isn't to that level, and then you checked it out and did your due diligence.
Well, the other thing I was going to say too, Gary, is that I think people get very scared when they start feeling like they have to confront something. Like I said in one of the earlier episodes that we did, had a client that has a history, like Marilyn, of mental illness in her family. And part of the reason why she didn't want to check it out is because, oh my gosh, I don't want to have to deal with that. And I don't want to have to think that I even have something close to that, right? And so I said, and we talked about that, what you resist persists. And to Gary's point, guys, if you do have something and it's bothering you, it may not be as big as you think. And let's just say the worst case scenario, it is. You either have borderline or bipolar disorder. Okay, let's say I have diabetes, or I have a broken arm, or I have, whatever my issue is. We all have issues. And if you think about it, Marilyn was one of the brave souls back then talking about it. I certainly didn't ever hear about Vivian Lee having bipolar disorder, and to the extreme. We didn't hear that back then. She was one of the few celebrities that actually did talk about it. It was always hush hush, and we certainly didn't hear about Frank Sinatra as well. I want to read a email that we got from somebody. She says, "My name is Lisa, and I have bipolar disorder. I have medication. However, I went off it because it makes me feel lethargic. I am a creative person as I'm a designer, and I just feel being on the medication makes me feel less creative and whole. However, after not being on it for a time, my mood gets dark and I get very depressed, and I'm not motivated anymore, and the cycle then continues." We actually got another email that says the same thing. So Gary, this is a big one for people that are creative. They're on this medication. Hopefully it's improved, and I want you to speak to that. And how do you deal with that when you feel like the medication kind of dulls that creativity?
Well, there's quite a variety of medications today. And so finding that balance is sometimes trial and error. And it means following up with a physician or a psychiatrist that you really trust. And these are disorders that, you might want to begin the conversation with a primary care physician, which is a great way to start. But the likelihood is for these disorders, a relationship with a psychiatrist would need to then be developed. And that's how these medications are prescribed and monitored. And so, it would be important before anyone went off of medication to consult with their doctor, because sometimes going off meds, kind of what we call cold turkey, can be very dangerous. And so sometimes medications, to go off of it, one would need to titrate. So there'd have to be a very strategic, lessening of the medication over a period of time before you go off of it, to make sure there's no horrible side effects of going off. And so that's a conversation with a doctor. This medication isn't working for me, and not all do. Everyone reacts differently to meds. What works well for one person might not work well for another. So you've got to find your fine-tuned balance. But once you get there, then you have smooth sailing. So, that's very important to seek out your doctor to consult about that. Now, I do have to say there's a valid point in what this young woman discusses, which is, the depressive state is very what's the word? It's just so devastating for folks that sometimes the bipolar mania or the hypomania, it's just more desired by the person experiencing it. And so the medications are not meant to take away the symptoms, but they're meant to kind of reduce it. So reduce the mania. And at no point do the symptoms completely go away. And so what she's noticing is that when the mania is more contained, she doesn't feel as creative as she normally would. And so I don't mean to minimize it in any way, because I hear what she's saying, but if we try to, I think it's always very important to talk about some of the mental health illnesses as we do the physical health illnesses. And I like when we can use the example of diabetes, because for some reason it's less stigmatizing. So with diabetes, the main issue is you can't eat the sugar, right? And so, you really have to control the diet. You might need insulin. You might have to have, sugar-free substitutes. Sugar-free is never going to be as good as sugar and fat, right? The real thing that roll on the tongue. So, so yeah, life has to be a little bit different, and you might have to make some sacrifices. However, the bigger picture, though, is the ability to stay out of the hospital and stay out of a crisis and stay out of a very negative situation that could lead to detriment in your life. So it is about that balance. And there is, we have to acknowledge for this woman, there's a little bit of grieving and loss of what she loves about the mania. And we got to acknowledge that. And that's a great topic to address in therapy. So the medication isn't alone. The medication can contain us to the point where now we could do the talk therapy. And once I think this young woman stabilizes on a med that works for her, then these are good issues for her to discuss in ongoing therapy with a clinician who might not be her prescriber.
The other thing I wanted to say too, Gary, is that I get this a lot, and I want to make sure, and you said, see their psychiatrist. There are a lot of doctors out there still today, even with the epidemic of the opiate addiction. Some are being much more mindful, but still, I think I want to make sure that somebody that is looking at changing their chemistry in their brain is also looking at their whole entire body, mind, body, emotions, and soul. So as Gary said, do some journal writing. Make sure you are resting and not overdoing it. Make sure that your diet, particularly your diet, is in rhythm with what you're trying to combat. Because a lot of times what happens is that's what happened with Marilyn, and you get into this addiction cycle, right? And that becomes the challenge. So I want to make sure that you find the right psychiatrist, and you have a psychiatrist that looks at the body and the human body holistically, not just by being a drug pusher, especially if you have an aversion to taking medication. But as Gary said, there's a give and take here, and being able to kind of come into rhythm with yourself and be able to talk through some of the stuff, you might be able to reduce your medication over time. But don't just do it abruptly and say, you know what, I'm off my medication, which we hear a lot happens with, especially with bipolar.
Yeah, that could be extremely dangerous. So, there are resources out there. There's SAMHSA, which is the Substance Abuse Mental Health Service Administration. There's also the National Institute of Mental Health. They've got great resources online, and you really have to do your research in finding a psychiatrist. Most of us have to follow our insurance plan, so we look for a provider on the plan. But once you have a list of your providers, it's incumbent upon us to do the legwork and the research, and to read the reviews on Google, and to talk to other folks. Support groups sometimes are a great way to link to a prescriber, or to go to lectures in the community, in the mental health community that might be out there, where you can actually see some of these prescribers present to the community, and you'll have a sense of what they're like. And you can tell a lot by their speaking on how they might address you as a patient. Another important issue, I think, with bipolar disorder is, especially in the mixed state, the risk for suicide increases. And about 50% of people with bipolar disorder also attempt suicide at least once. So, this is pretty serious. And definitely, I think we talked earlier about, during the depressive episode, someone might not have the energy to take action on their suicidal thoughts, but I caution you, anyone who's depressed, can have a risk for suicide, especially if they're having those thoughts. So that has to be taken seriously. But sometimes the energy just isn't there. But in a mixed episode where there's the impulsivity and the poor judgment, that might then fuel the fire of the depression and be just enough for someone to take action. So, this is very important. Suicide risk, it's not so easily predictable. And for many years, we thought that if, people, strategically plan suicide in a very methodical, calculated way, giving away of objects and, that sort of thing. What we're finding today is that suicide tends to be much more impulsive. And so when we're doing suicide risk assessments, we really have to take that into consideration. So certainly family history of suicide, mood disorder, substance abuse, all of those things increases the risk. And so.
Yeah, I was also going to say too, is in Marilyn's case, right? And Gary, it took me a while to come around to this side, because I came into the Marilyn kind of life story thinking that she was for sure killed, right? I mean, that was my feeling at the time. And hearing her story and really hearing the reality of her life and really the mental illness that she had. Remember you talking about spontaneous suicide or instantaneous suicide. And I remember thinking, because I felt that same way about Marilyn. There's no way, because she didn't say a note, she didn't, plan it, etc. But, if you think about it, the day that she actually did pass, she would lack of sleep, right? The painkillers that she was on from both, Dr. Greenson and Dr. Engelberg were monumental. She would have been, these doctors would be put away in jail today for that kind of standard of pill giving. And then you have the ability of the fact that, being addicted and her bipolar borderline personality disorder, that level of being able to do that, it was like a perfect storm.
Exactly, how all of that converged. And so, the recent studies about suicide is that they are more impulsive. There was this study that came out, it's pretty significant. And it was an interview of subjects who had attempted suicide in a very serious way. And so the only reason why they were still alive and able to talk about it was because there was medical intervention. But these were like pretty high lethal risks of suicide. So of course, these would involve some gunshots that didn't result in death and a lot of overdoses. And so when these folks talked about their experience just prior to the suicide attempt, 25% of them said that they weren't thinking about suicide 5 minutes before they took action. And about 70% of them said that they weren't thinking about suicide an hour before. And so, something happened within 60 minutes or within 5 minutes. And so, that we've been talking about borderline personality disorder, and we've been talking about bipolar disorder, and talking about those two disorders, we're hearing more about the abrupt mood shifts and the extreme emotional pain and the impulsivity and the poor judgment. So you can see how, chemistry in the brain can lead to these very abrupt changes that can have very serious and fatal consequences. And so I think it's just important that we highlight that. The people who were around Marilyn at the time, I think some of her closest friends, they had a layman's understanding of what depression was. I could think of like Eunice Murray, her housekeeper, who in all of the interviews in her book says, I wouldn't characterize Marilyn as depressed that day. But then she goes on to describe observations which clearly indicate depression, irritability, mood issues, that she never dressed that day. She remained in a robe. She didn't have anything to eat. She hadn't slept in a long period of time. She was very irritable. She stared out the window. I mean, all of these kinds of behaviors to a mental health professional would be like, these are pretty classic, but we don't have, even today, 50 some years later, we don't have a clear understanding of mental illness. And we might have these kind of rudimentary notions about, well, you got to be tearful. Well, depression doesn't always look that way. Sometimes depression looks like irritability. And there's this cluster of 3 symptoms, which is agitation, irritability, and anxiety. And when those 3 tend to come together, that increases risk for suicide. And definitely in bipolar disorder of the hypomanic type or the mixed state, you definitely have that trifecta going on.
And I was going to say to you, Gary, I'll never forget when Douglas Kirkland was on the radio show with us when we were doing Goodnight Marilyn radio, and he talked about his experience with Marilyn, right? That, you know, for those of you, Douglas Kirkland, just remember, I actually have it in the other room of, it's the famous black and white bed shots of Marilyn looking very luminous, let's just say, on the bed, and very had that sex appeal, right? And I remember he was saying that that day was just magical, right? She was just so lovely and charming, and you know, he'll never forget that time in his life of that shoot that day, and that he was going to go ahead and then go back. It was like either several days later, I don't know when it was, but to give her and show her the proofs. And it took her forever to you know, answer the door. And then when she finally did, it was like, go away, I don't even want to see you. So, you know, I think that for anybody that's listening to this, think about it for either a loved one or yourself. If you're having these kind of moments where they just feel so magical and lovely and wonderful, and you're extroverted and you're creative, and that's wonderful, but then a few days later you're like, you can't even get out of bed, you want to be able to look at that and do something about it that's going to be holistically helpful for you in getting help.
And there's so many very effective mood stabilizing drugs. You know, in Marilyn's day, in post-war America, lithium was being used as a mood stabilizer, and just in an experimental way, probably in inpatient settings. It didn't get approved until 1970. And now we have, you know, so many mood stabilizing meds and Abilify, and ones with far less side effects. And I did ask Dr. Engelberg if Marilyn had ever been started on lithium, and he never directly answered my question. And I wondered if she would have had that access. But back then, the lithium, one of the side effects was weight gain. And I know, and this is just my speculation, but in the very late 50s, when she was really having her struggles with, beginnings of her struggles with mood disorders, you know, she had gained some weight, and the critics were beginning to mention it in the reviews. So, you know, unfortunately, if she had been taking lithium, or if she would have considered taking lithium, that might have had an impact on her ability to comply with it. And so now, you know, now we have many meds that have far less serious side effects.
So, Gary, is there any closing thoughts you'd like to say on this topic of bipolar as we carry and continue through this month of Mental Health Awareness Month? What would you like to say to the people out there about bipolar?
Well, I encourage people never to negatively refer to someone as being bipolar or acting bipolar, because in our culture and in our slang, that word has now come to mean, oh, someone who's just acting out, or maybe someone who's has just a strong reactivity. And that's not a respectful way to call someone. We certainly, you know, we don't refer to people as acting cancer, you know, so we have to be mindful of mental health terms used in negative ways. So, you know, it's important to understand, it's our, you know, we're all responsible to learn more in this life, and to increase our awareness, and to have more compassion for folks. So we should read up about bipolar disorder. And when we do, we'll see that if anyone were to be diagnosed with this, this is the best time in history to be diagnosed with it, because there are so many effective forms of treatment, and you can live a normal, wonderful, productive life with this disorder. I know many people who do. I've worked with many people who do. So it is not the highly negative thing that it might have been in previous generations, as are so many other illnesses these days, because we just know so much more and we can treat them.
And my last thing to say is that look at Marilyn, look at how much she achieved, even with not being diagnosed correctly at the time, right? So just think about it. If you are proactive and you look at this as an adventure and something to explore, whether it's yourself or a loved one, the key here is to get help and to know that you are not alone. So I hope you enjoyed and you found this topic on bipolar helpful. If you haven't watched the other episodes on borderline personality disorder as well as sexual and physical abuse, suggest that you do, because what we're finding, even through all of these sections of Marilyn's life, and we will get into it in our next section of our last video segment, is how resilient and strong she was. So that means if you are dealing with it or a loved one that you know, they also have the ability and the resiliency and the strength in them. And hopefully Marilyn can be the courage to take that step and get healed. So on that note, you want to leave us with our wonderful Marilyn thought?
We're holding a good thought for Marilyn and other people who are living with the challenges that she lived with.
And we will certainly hold a good thought for you.